what you have to do, because that action is so important. And the workshop yesterday was really around not having enough information and then building that up and seeing how you then use the gentleman's point, descriptive methods. But again, he was quite right, because going further on, you also then have to do a little bit of analytical methods to really get to the point of action and policy information. Having said that, it really is a pleasure to chair this first session. Looking through the agenda, I think we have a stellar list of speakers. I would just then try to kick off really by inviting our very first speaker for this plenary session. I wear my glasses. Stacy Grebe. Did I get that correct? Grebe. I knew there was something wrong with that. And who is Stacy? Stacy is an epidemiologist serving as a senior technical advisor in the Epidemiology and Strategic Information Branch in CDC, Nigeria. She supports translation of data into action, including implementation and analysis of the Nigeria HIV/AIDS Indicator and Impact Survey, NIAS, and the Nigeria Multi-Disease Serological Surveillance using stored specimens, NMS4. Previously, Stacy worked as a science officer with the assessment branch at the Immunization Services Division, National Center for Immunization and Respiratory Diseases, supporting vaccination assessment activities in the United States, and the VaxView websites. She also worked on projects focused on measuring vaccination hesitancy, something I think would be quite important for us now as we reflect on the growing issues with measles across the world, including developing and testing a questionnaire set to measure vaccination hesitancy across surveys, and a demonstration project using cognitive computing to assess text data related vaccination coverage and hesitancy. Now I'm getting slightly lost in all this, but I'm sure she would explain a lot more. She is also a member of CDC's successful scientific writing training team. Dr. Grebe, I got that right, received her Doctor of Veterinary Medicine from the University of Illinois at Urbana-Champaign, and her Master's in Public Health in Epidemiology and Biostatistics from the University of Illinois at Chicago. She came to CDC as an Association of Schools of Public Health Fellow in the National Immunization Program in 1997, and joined CDC as an epidemiologist in the Division of HIV/AIDS Prevention in the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention in 1999. She served in Zimbabwe and India, supporting President's Emergency Plan for AIDS Relief, PEPFAR, activities, and in Sierra Leone on the Sierra Leone trial to introduce a vaccine against Ebola trial. Stacy would be talking to us on laboratory surveillance, integrating CDC, PEPFAR efforts, and the global health security agenda. Stacy.
Good morning, everybody. Okay, since we're doing show of hands, how many veterinarians out there? Let's hear it for the veterinarians. When I was first asked to do this talk, I was so excited because last year I had just moved to Nigeria and I had other commitments and I couldn't be at this conference, and I was very sad. So I'm very grateful to be asked to do this talk. I'd like to thank the chair. I'd like to thank the organizers for this, but It's also the topic of laboratory and surveillance. This has been near and dear to my heart. How do we take laboratory and turn it into surveillance? Because I am an epi, and I've already had the talk with the laboratory person this morning. It's like, well, actually, they have to work together because that's how we get data turned into action. So, let's go to the next slide. How many people know about NICE? Nobody knows about NICE? There's a few people waving their hands. NICE is very nice. It's okay. So let's see if we can get this. Not so much. Okay, we'll just go like next slide if that's okay. So it is a nationally representative HIV population-based survey. Nigeria got it done from July to December in 2018. It had to be done. We needed the data for planning purposes and funding purposes. And Nigeria stepped up and Nigeria got it done. We targeted 100,000 households. We targeted about 170,000 participants. We actually got more participants. We had to file an IRB amendment because we had more participants, but we got to go to less houses. And we asked people, would you be willing to have a remnant specimen stored and allow us to test it for future health purposes? People said yes, an overwhelming majority, well, almost all of the adults, but still a huge percentage for their children. And so we have those specimens, and next slide, but we were able to answer for NICE our primary objectives, which are, what's HIV prevalence at the national, zonal, state level, HIV prevalence for children at the national level, HIV incidence at national, viral load suppression, so we can find out where we're at with 90-90-90, an important measure of HIV control, but also viral hepatitis, and that was just released recently. But next steps, next slide. Now this may be difficult because that's a little video, and I don't know if IT can show the little video. But we want to ensure that we put a lot of investment from PEPFAR into NICE. And we want to make sure that this continues to provide returns for the Nigerian people, not only in the money, but people literally gave their blood. So we have stored specimens, as I mentioned. We have plasma and dry blood spots. Average about 4 mLs of plasma for adults, 2 mLs for children from ages 2 to 14, and we have DBS cards stored away. So we can't get that video showing? Well, the video shows what 1 million specimens look like. It's a lot. And actually, the video doesn't show 1 million specimens, it only shows 2/3 of our specimens. We have another room that has even more specimens. And what we came up with was the idea of something called the Nigeria Multi-Disease Serologic Surveillance Using Stored Specimens. It doesn't really roll off the tongue. So it's NMS4. And what we're looking at is, can we go ahead and measure prevalence estimates for malaria, for vaccine-preventable diseases, for neglected tropical diseases, for other health diseases. So next slide. So the goal was, can we develop a single integrated surveillance platform to measure disease prevalence? And as I mentioned, we have prevalence for malaria, water, sanitation, hygiene, WASH, neglected tropical diseases, and immune status for VPDs. And next slide. We all know there's a lot of laboratory people here. We all know the strengths of serologic testing. It's wonderful. It's told us so much, and it's guided us so much. So traditional serologic testing, ELISAs, IFAs, and we've used them a lot. We trust them a lot, and there's WHO gold standards for that. and we clearly understand what the results mean. So we also, one of the things we found out in NICE is many people said they were HIV negative, that were then HIV positive. And we knew our viral load was at a level that a lot of those people who said they were negative but showed positive, and we now have the data to show they're on antiretrovirals. They probably know their positive status. They just didn't feel comfortable saying they were positive. But we now have data to show how many people know their status, which is an important thing for control. So we can use laboratory for that. Next. So, weaknesses. When you're doing the assays, you need a separate assay. You can't put a test for HIV and a test for measles in the same well. You have to do 2 different test runs. And you have plasma or serum volume requirements that are usually quite large, and labor is a lot. Each separate test run is a separate time. So the next one, next slide. There's a picture of camel here because I just like the picture of a camel. How many surveys can you say you used a camel? So can we maximize the impact of using laboratory techniques? And can we integrate the investment we had from PEPFAR into global health security? So next slide, and you can go to the next slide after that. So multiplex bead assay. Next slide. On the top in the center, the little tall machine on the left is called a MagPix. I think it's really cute. Next slide. What multiplex bead does, instead of having a flat surface for an ELISA, somebody got the bright idea to put that on a bead. And if you color code the bead by different dyes, it's even better. You can get many different colors, and you can tell the machine the different diseases. So one color will always be measles, another color will always be tetanus. So you can customize this, you can couple the antigen to this, and then next slide. This is the best part. One well, all those little beads going into the one well. We're testing, in this case, in this little figure, for 5 different things at the same time in the same test run. So the advantages of MBA, next slide. So we can do multiple assays at the same time, multiplexed. That's what we call it now. Low sample volume, less than a microliter, or a 6 millimeter punch from a DBS, just that. And multiple assays can minimize labor costs. So if you're doing one ELISA, additional cost to do another ELISA. It's additive. It's the addition for multiplex is the cost of another bead. And it does compare to other assays. We're going to go through the next ones pretty quickly. So the next slide. They did comparisons to existing gold standards for onchocerciasis. And you can see there's great agreement at the top of the figure on the left. And when they went ahead and mapped it out on the right, they were able, that's how they go through and they choose which antigen they're going to use with the bead. Next slide. So how can we use this to maximize information? You can go ahead and do standard surveys, you can do monitoring and evaluation, and it has been used around the country. But the last bullet, the performing surveillance for disease using MBA testing into other routine surveys. We've already done NICE. We have 1 million specimens stored from over 200,000 participants. We can test that. Right now, it's just plasma and DBS sitting in a freezer. I see data. The laboratorians are going to give me data. That makes an epi happy. Next slide. So there's laboratories that we're moving across, CDC is moving across the world, setting up laboratories. Next slide. The requirements for running the test. We need continuous reliable power supply. Generators and UPSs help that. Running water and a source of distilled water. Temperature controlled room. The machines want to be cold during the entire time they're running. Refrigerator and freezer. dedicated computer, a biosafety cabinet, sufficient funds, and trained staff. Where do you think we have that in Nigeria? The National Reference Lab. And, next slide, one of the things we did with NICE, because it was a NICE study, we trained a lot of laboratory staff. So, bead coupling, we need beads. That currently is being done in CDC Atlanta for infectious diseases. There is going to be other commercial labs that are interested in doing this as well. Assay standardization, that's being done for more and more diseases. Training. Really, if a laboratory scientist can run ELISA, they can probably run a multiplex assay. And a laboratory staff member can do about 700 specimens per work week. And that can be sped up if you have people doing preparation of samples, of specimens and things. So you can get a lot of throughput, on one machine. There may be more than one machine at the National Reference Laboratory. We'll get to that later. Next slide. So CDC has developed panels for infectious diseases. Multiplex technology has been around. It has been used for other diseases, but not for infectious diseases. So CDC has developed panels. For the ones in blue are the ones that have been standardized. I'd like to point out the last one, HIV-1 and HIV-2 antibody and incidence. NICE is helping because NICE had specimens that we knew were positive, and they helped with validating a hopefully new multiplex assay for HIV-1, 2, and incidence. Next slide. It's not the answer for everything. Some things don't work. Hepatitis B surface antigen seems to have problems coupling to the bead. It can be difficult to produce an antigen, and there are several diseases for that. There's not really there's problems with limitations of not having positives and negative control panels and lack of sensitivity and specificity. There's a lot of cross-reaction with certain diseases. So, but, next slide, multiplex assays can help, and they can serve as a surveillance platform. One thing is if you're putting all those beads into one little well, you're getting all those experts together into one room and talking about a protocol about how to do this and how to analyze the data. But it's going to provide a lot of data on population immunity, what are community differences with diseases, what are overlaps between diseases and vaccine preventable disease immunity. So there's a lot of information that come from here. Next slide. Next slide. So we'll go through this really quickly, but onchocerciasis, they're looking at the bugs. I'm not into bugs, but little crawly, creepy things. And then they're looking to see where they need to do assessments, and then looking at where do they need to map things out. And people who know the onchocerciasis program may, next slide please, may say, but we have an onchocerciasis map, and it's detailed. This map, there's not a lot of footnotes under it, but it has data from many different points, and it's not always comparable. We're going to be including an onchocerciasis bead in this NMS4, and we will have, for the first time, on humans across the country, hopefully if we can test all participants who consented, we will have their exposure history to onchocerciasis, and that helps us towards elimination of river blindness. So, next slide. So considerations for use. The startup costs are not prohibitively expensive compared to other surveys. So, and other technologies. NICE was quite an expensive survey. This is a little bit on top of that to get it done and to get the information out. And we are looking at regional support for laboratories and collaboration with CDC Atlanta, with the National Reference Lab to make sure that we can have a standardized test. Countries don't do bead coupling yet, but It's early days yet, it's early days, so this may be something to think about. I've been talking about a crawl, walk, run. We're gonna start, going slowly to get this new technology to us up and running. And then let's see where we can go from there. There's a lot of steps we have to do. We are having, hopefully, training start next week. A lot of things need to be done before training can start next week, but we're hoping we can start training next week and start testing, maybe towards the end of next week. So challenges and consideration, next slide. So it does take more than one hand to lift a roof. So it requires a lot of upfront coordination and people who don't really talk to each other. I'm the project manager for the project, and I've also gotten the term, does anyone understand the concept of herding cats? We have a lot of people who don't necessarily talk to each other. We have our laboratory scientists, our epidemiologists from different groups, and our statisticians from different groups. And everybody is brilliant and knows their study area. And we're trying to get them to branch out and look where their study area overlaps another study area. This is the first step to where we're going to be in analysis as well. And we have to do a lot of upfront coordination of different agencies. So it's been fascinating to work with people across the government of Nigeria and across US CDC and getting people to come together and really think about what we're doing. Not only for Nigeria, but NICE is part of something called a Population HIV Impact Assessment Survey, a FIA. There are about 15 or 16 other FIAs out there around the world. We're the first one to start testing. So the next challenges and considerations. NICE had its own very well thought out study design. It's a very good study. I'm slightly biased. But there's differences between what we did for NICE and our sampling frame for NICE and what we chose for NICE than maybe what may be needed for measles or malaria. And we're going to have to think about that as we do the analysis, as we look at that. We have to be very thoughtful going forward. Next slide. As we now have centers and labs across the world, how are we going to get comparable data, from one lab to another? How are we going to harmonize? We have quality control put in for NMS4, and we're going to be following that. And we are going to be helping write the book on good practices of how to take this technology and do it on large surveys. And we have some of the methods, or some of the SOPs, we're going to turn that into robust methods next. But we're still working with something that's rather new. Even for malaria and other NTDs, some of these tests are very new. And they're still defining what positive means, what negative means. And we will be helping that out because they need data from a diversity of settings. And we're looking forward to getting those data for Nigeria. So next steps, next slide. And we are in protocol development. We're supposed to start testing on Monday or on Tuesday. So I was commiserating with Bronte. I'm a little bit nervous right now, not just because of talking. I usually don't get nervous about talking, but I'm waiting on protocol approvals, and I'm supposed to start a study on Tuesday. We hope to start training on Tuesday. Keep your fingers crossed for us. We have equipment, supplies. We've bought equipment. We've borrowed equipment. We're still shipping one piece of equipment. We've installed a lot of equipment. We have standard operating procedures that the team will be trained on. We are very grateful to NCDC for serving as the in-country coordinator. They've been shown great leadership through this. And we are looking to prioritize children. We have about a little over 32,000 specimens or children participants. We have consent for storage and future testing. So that's what we will start with. And we will have, hopefully, very shortly, the next step. Test, analyze, action. The whole thing is to go ahead and to make sure that we have data for action. that we can go ahead and provide Nigeria with the data to inform public health response. And our timeline, it's pretty aggressive. So we're just hoping that we can start next week. Next slide. A lot of different organizations, both government of Nigeria and multilateral. And next slide. And a whole cast of cats at CDC have helped make this happen. And our final slide. So I just want to say thank you, and I also have a very sincere apology. I have to, because I mentioned I would do training, I have to go catch a plane literally in about 10 minutes. I have to be someplace else to get on a plane. Or to go to the airport to get on a plane. So I apologize that I have to leave before. I really wanted to be here for this conference, but I do want to thank the chair and the organizers for giving me this opportunity to introduce you to NMS4. Thank you.
Thank you, Stacey. I think she deserves another round of applause. Thanks, Stacey, for a very interesting presentation, because Stacey is really moved for time. We would amend the program a little and give her the opportunity of answering one or two questions. But before we do that, I think three things stuck with me as she was talking, and I think maybe with a lot of people here. One is nice is nice. So I think nice is nice, actually, because that is a really big survey, isn't it, that we've been able to complete in Nigeria for a very short period of time, which gives us a much more defined understanding of what our HIV prevalence is. Second one, I think, is the NMS4, which looks like it's going to have huge potential, isn't it, Stacey? And the last bit is data for action. Those are my take home for that. So I'll just ask if there are any questions for Stacey while she's here. Oh, Patrick has his hands up. Oh, yeah. So we have one. Any other one? Let's just see who else we have for Stacey before we go on. All right. Whilst everybody's trying to reflect on the numbers and the opportunities and the great work that Stacey has elaborated on, Patrick.
Okay, thank you for an excellent presentation. My question is just based on, today is the World Suicide Prevention Day. And it's just a reflection of the public health issues that we have to deal with currently, the non-communicable diseases and mental health issues. So is there opportunity for MBA in the non-communicable disease world, biomarkers and what have you?
For this, thank you for the question. For this, there are many people who are laboratorians who could speak better. The MBA technology, I believe, was developed for non-communicable diseases, I believe in cancer, detecting certain cancer, and there's a fair amount of panels there. A lot of them have been used more in diagnostics, and when we've been talking with the company, Luminex, they're really focused in on diagnostics, and even moving into public health and surveillance is newer to them. This has been adapted for infectious disease, but there are tests available for certain chronic diseases, yes.
Question for Stacey while she's on her feet. Any more questions? Okay. Sorry, was there someone? Okay. So I think it just gives me the pleasure of again thanking you for a very interesting presentation. And we'll be, okay. So, something has just been whispered in my ears. So while you'll still be standing on your feet, I believe, and well, you can look at me. before then.
I'm looking at the bright, shiny thing.
All right, so I have been lumped with another action for you this morning. And I think really it's a sign of appreciation for all the work you've done and all the work that we're looking for you to do some more, certainly under the NMS4, which to me is really sounding very interesting, and we'll be looking to see how that actually pans out for the benefit of Nigeria, obviously. So it gives me great pleasure to give you, since you are going to be running off now to more important things, but we think we'll take...
Not more important.
Okay. We'll give you this award on behalf of the local organizing committee, and certainly on behalf of all the people you've worked for, and more importantly, on behalf of Nigeria. Thank you. Right. So I did say we had a stellar list of speakers. So we started off with the laboratory surveillance aspect, which I believe we all found quite interesting. And then we're moving on now to another aspect, which you might not quite see how that works with it, but I think the speaker is going to make a good job of it to see how that actually works into global health security. So in introduction, Valerie Nkangan Bimo, do I have that right? She gives me a thumbs up, is going to be our next speaker. Dr. Nkangan Bimo has been an integral member within the Global Development Division at the Bill and Melinda Gates Foundation for the past 12 years. Within BMGF, she pioneered and executed the emergency strategy to respond to all major world disasters. That's big, including the Haiti earthquake in 2010, the Ebola breakout in 2014, and the Nepal earthquake in 2015. Additionally, Dr. Nkangan Bimo designed and implemented a critical strategy for agriculture development in West Africa, with a focus on, of course, Nigeria. She holds over 20 years of direct experience in the field worldwide, and is passionate about building local capacity within communities and national institutions, fostering innovative solutions and sustainable growth that results in lasting change. Before joining the Bill and Melinda Gates Foundation, she held various roles at the International Rescue Committee, most recently serving as Senior Technical Advisor for Health in the Democratic Republic of Congo and West Africa. She has experience with a wide variety of NGOs internationally, with extensive experience in emergency relief, as well as clinical and public health. Regarding education, Dr. Nkangan Bimo received her MD from the University of Côte d'Ivoire, an epidemiology diploma at the University of Paris, and a master's in public health from Madrid Autonoma University. Join me in welcoming Valerie to speak about philanthropist perspectives to mitigating disasters and health emergencies. So we've moved from laboratory to philanthropist. A big round of applause for Valerie.
Thank you, Chair, and thank you, everybody. I have to make a disclaimer first. Although I'm speaking as a philanthropist, I have to make a disclaimer that the biggest philanthropist, I'm working for a philanthropist. I'm probably not a philanthropist yet. And I think my presentation will be coming to talk about the Gates Foundation, the Bill and Melinda Gates Foundation, really briefly, how we look at our strategy for disaster and emergency response, but also some examples for public health emergency preparedness and response. And finally, some of the lessons learned and some of the guidance we'd like to have. Okay, I'll start with one of the quotes of one of the greatest philanthropists, is because I think they asked me to talk about philanthropies, is Warren Buffett. As you know, he has been part of one of the co-chair of the Gates Foundation, and he always said that we own, and based on the Gates Foundation, we also, Bill and Melinda really believe that all life has equal value, and this is what drives the foundation work in general. As you know, it has been almost, we are still a young, comparatively, if you look at the Rockefeller and all the other foundations, we are still young in life. But I think in the last 20 years, we have been able to accomplish a lot, 19 years now, and next year we'll celebrate our 28th anniversary of the foundation. What we do, in general, what we do is really making sure that all life has equal value and everybody deserves to have a productive and healthy life. This is, in general, what we do. And this will go in different sectors about young or survival thrive, about agriculture, health, vaccination, combat disease, but also livelihood, economic value. And we always have this, and I like this because I'm one of the African in the foundation. If you want to go fast, go alone, but if you want to go far, go together. And this is how the foundation are working. We cannot do the work because we are not on the ground. We have to partner with different people. Then we work with a lot of different organizations, including the Nigeria CDC of the government of Nigeria in general, to accomplish what we want to do. And of course, our value is really about optimism. And if you have heard a lot of Bill or Melinda talking about the impatient optimist, because we really believe that there's so much more that can be done. And we really believe that we can actually accelerate it. And it's not acceptable that it's not yet done when we know it's possible. But also collaboration and rigor. A lot of people who work with the Gates Foundation know that we sometimes a little bit too much about data and numbers, and but actually we really taking innovation seriously. One of the things that we really look at is the innovation is looking at like, how do we take a risk? And as a philanthropy, we can take risk that other donors cannot. And we feel like this is a space where we can actually move forward, taking risk, be catalytic for actually other people to take it to the next level. For the emergency response, one of the things that we look at the philanthropy is really to look at basic innovation to actually transform the world. And that, for me, is where the philanthropy played the role. Be catalytic, taking risk, and actually show the case for other people to take it at scale. I want to come back to the reality of the world. We live in a world where we see an increased number of crises, disasters, both natural, conflict. We know that there will be more and more people forced to displacement, there will be more migration, but with the climate change also, we'll have an increased number, and this have a direct impact on health. Just because of the migration, we see even the European, the migration, the disease will change the course, but also because of the poverty and the movement and the crisis urban, we have a change in how our health system is functioning. We also know, unfortunately, that there's less funding. The funding are more scarce. We need to change the way we are doing things because we cannot continue everything going up, but the funding is going down. Then we have to change the way we think about that. And one of the things that we're really looking at as we look at the foundation, a lot of people don't know the foundation for the humanitarian because we are not big. It's not our priority. It's not what we are doing. But because of the circumstances in the world, we know there's no way we can not do that because these are the places where the poor and the poor live. And one of the things that we look at is really to save life, primarily to save life of the people because this is the only way you can go to the productive and healthy life. And we are able to provide funds for rapid response. But at the same time, we also believe that there's a lot of disaster or a lot of emergency, especially public health emergency, where we can predict, we can prevent, or we can react really fast. And by reacting fast, we can actually cut down an outbreak rapidly. And we believe that the more we build the capacity, locally and national institutions, the better we'll have a better preparedness, therefore a better response. But also, there's a lot of way where we can really start thinking about how can we change with a lot of, I'm glad that Stacy was here to talk about how the progress on the innovation and how can we take it and change the way we are working. And one of the things that we do is that we work really in different types of disasters across the world, as we mentioned earlier, in the different places, but also we do a lot of work with the different partners. We work with university, we work with government, we work with NGOs, we work with local national NGOs, we work with private sector in the way we're doing the work. But we use the different way the foundation have to use their way. That means that the voice, the grant making, and the convening power. I'll just pass quickly on these ones. In the relief, this is one of the big ones that we saw in Mozambique this year. These are some of the things we know will happen, and we have to start really thinking differently about how we start thinking about that. It will not be, we are always in a reactive mode, and we have to start thinking about how to look at it more in a proactive way and be prepared better to put a system better. In the foundation, we do rapid response for Mozambique, etc., and we can actually put funding really rapidly. But I think this is not the way I see our more impactful way. And, okay, can you move it ahead fast so that? Okay, I'll continue until it's coming back. The other piece that we really think about is to look at the innovation. The foundation is really looking at innovation in the normal setting, in not necessarily the poorest. We have agriculture, we have health, we have sanitation. And one of the things we are looking a lot is to look at innovation. How do we take what is already existing? And the case of when Stacy was mentioning is something that we use for non-communicable disease that can be translated. We don't have to always reinvent the wheel. We don't have to always go back to start from scratch. And there's a lot of possibility for us to actually move faster. And then for the capacity building, one of the things we think is that the local are the first responders when anything happens. And then actually having their capacity, they will be there before and after. And actually, because they know better the community, they can actually move things faster. And in this way, we work with really different type of level of academy leaders, government, private sector, because we think it's a whole self who making the work with. And I'll go quickly here. Now, what I want to do is to really move quickly for today. How do we prevent and actually respond to disaster, especially public health disaster. And one of the examples, I want to take the example of the public health emergency operation centers that are a critical stage. And as you know, after the Ebola in 2014, one of the things that we see is that the big part of it, if you can detect really rapidly the first case, will not go to the big disaster. And the magnitude is so important that we cannot continue just waiting until we have a big outbreak and then start reacting, because the consequences and the loss, both in terms of life, but economic loss and all the disaster is actually too much. Then one of the things that we look at as we see the big part of what was happening when we have the Ebola is that a lot of the national institution was not ready. There was no system in place, there was no coordination, there was one-off things, and it took for months for even the international community and the coordination to actually put together. And there's a lot of discussion, especially when we look at now to look at what does that mean for a crisis management? Is governance, human resources, financial management, organization structure, community engagement, and operation coordination. And based on that, the Africa CDC have been actually coming to ask each country now to have some of the setting. And I know in the regional, West Africa is one of the more advanced because we have now, with the WAHO, we have a West Africa CDC. To start implementing each of the country, how do we do that? And I know Nigeria is one of with the NCDC, to actually establish a real way of moving to that direction. And one of the things that we start really thinking as we think about philanthropies is not so much about the money. Of course, money is important. But if you look at the money that the foundation put in the public health, it's a drop in the bucket. But if you look at the impact, it's about disruptive mindset. It's about changing the way and showing the case and creating opportunity. And this is the way we see the way we should work. And then since the Ebola, we started since in 2014. We put almost 50 million for the response, but we also start thinking about it's not possible to continue this way. We have to engage a bit more with some of the countries to look at strategic planning, operationalization, and to go moving a little bit more in that direction. And we have been working across the continent with different countries, starting with Senegal, actually, when they had the case, or Mali. And we have been moving around in the continent with different type of intervention, but also looking at how can we look at the supporting and countries, but how do we also looking at helping them taking almost their own hands and own it. And I want to come back because I think each time we're talking about EOC, people think about the physical infrastructure. For me, the physical, we can even be under the mango tree and do a good coordination. The more important is really, you have the physical, is the people and the person and the system that is putting in place, more than actually the center and the physical infrastructure. And that is really important. And one of the things that you have to look is that you're required to have fast and effective. You cannot do that at the last minute. You need to plan in advance. You need to set it stage. You need to have planning. You need to have epidemiology. You need to be able to detect data rapidly. All that are essential for the country and the international work to move together. And we saw, for example, when we worked with the NCDC, 3 years ago, the meningitis outbreak, it was like, wow, how can 1,000 people dying from meningitis outbreak when we know when it's happening, when we know how we treat it, when we know what is the things? Of course, Ebola, but even meningitis. How do we actually prepare it better? And the next few years, 1 year later, the meningitis completely changed the pattern just because it was better prepared. Laboratories were prepared, people were trained, and that is essential because the loss of life can be essential when we look at that. And some of the key learning after a few years of actually elaborating a lot of the EOCs and working with different countries, one of the things that we saw is that it's 5 different areas that are important. One is the strategy, how to set up that EOCs. The scope, it's important to have to define the scope. And each country have a different situation. It needs to customize to what existing and not just creating a new center. How is it anchoring? Where is it situated in the thing? What type of resources is needed and what leadership? When we look at the effective strategies and the focus, we need to identify the champion. And I saw that really happening when in the country you have either the minister and somebody who is really championing and who believe in it. It's amazing how the strategy evolved rapidly. And how do we move that? How do we incorporate the different stakeholders is actually critical. One of the other things is that the limiting the scope of an EOC help establish a sustainable and effective emergency management system. Usually, we tend to want to do everything in once, starting from 0 and be doing 100. No, I think one of the things that we learn well is that you can have a vision for 10 years or a strategy for 10 years, but take step by step and move and getting stronger as you move, but don't try to go too fast and include everything, all the diseases, all the problems in one time. This will actually make it difficult for you to move. The next one is that where is it anchoring? And this is a lot of discussion in a lot of countries. Is it in the Ministry of Health? Is it in the surveillance? Is it in the disease outbreak? And each country, and I think there's no one person who can make the decision. It needs to be a collaborative discussion to understand the system and actually the strength of which services and the champion. This is what is important and how you look at that. The lack of training resources, human resources are really essential. But one of the things, and I think the field epidemiology is one of the big part of that, unfortunately, a lot of the EOCs, a lot of systems focus too much on epidemiology only. I think epidemiology is important and it's essential, but you need other skills. You need communication, you need some logistics, you need some finance. All that is important. Of course, the epidemiology will be essential to how you put that, but you need to have the diverse places, and we need to start looking at how do we skill these people because it will be a different type of system. The other one is that we need to require to have different skills. It's not just about the technical skill. That, unfortunately, we have a lot, but it's about how the management, how do we coordinate? Do we have somebody who knows how to even just run a big meeting? For those who were involved in 2014, Ebola outbreak, this was the biggest part of the problem. There was no good coordination, and people cannot sit at the same table and agree on something because it was chaotic. Do we have meetings? And how does that? Who is invited and who speaks? And this management are so important. And how do we engage with the security, with the finance, with the trades, with the transportation are actually as important to work on that. And here I want to really go to some of the reflection as we really think about what does it mean to build institution and capacity. I've been doing it for many years, and I'm a really firm believer that we need to really make that effort and having countries and institutions taking the lead. But for that, we need to believe in them. We need to really believe that they can do that. And I'm coming, of course you can do that, but I'm coming from the donors community where we always have the skepticism. Especially when you say Nigeria, they say, oh, is it a 419 somewhere? Are you sure? Can they manage it? And that is not right. If you cannot believe that they can do it, just don't start. It's important to actually have that belief, to build the trust. We have to get a place where they feel comfortable telling you where they cannot do something or where they don't have the capacity and where they feel confident. And even when they say they feel confident, the next day they say, we thought we were confident, but we are not. And how do you actually build that trust is essential. You need to stimulate the ownership. I have some program in some country who didn't go well because they didn't own it. And now I'm not going in a new countries or in a place if I don't feel like it's something they believe in or they want to own. It's the first place to be not a success. And you have to go with open-minded. And the open-minded is really important because sometimes you go with an idea and you get there because they trust you and you trust them. They start coming with something who have nothing to do with what you were thinking, but actually sometimes it's what it is. Then go with open-minded because that is where ownership comes because they feel they have a place to actually design it themselves. You have to hold hand. A lot of the time you can pull or push sometimes, and this is essential as you work with them. And be flexible. A lot of the time we come as a donor especially, we come with a proposal well written, okay, you need to do ABC, but we know the circumstances are not like that. The things are not working that way. There's a lot, especially in disasters or public health emergency, there's always something that you were not expected that is coming. Hard to be flexible. And be ready to support beyond your objective. You need to support their needs and sometimes not what is your needs. And that is how you also build the trust. But more important, and I like that sentence, is to say you have to listen with your ears, your eyes, but with your heart. This, for me, is the more important part because if you connect with them, if you send a set with them, actually you have a better sense that you guys will be creating something that is durable, sustainable, and actually serve the people that we tend to serve. Thank you.
I think Valerie deserves much more than that in terms of applause. Thank you, Valerie. And of course, I just need to reflect on the philanthropist and disaster and working together. I think we need to start from those principles. I just love them, and I think we need to highlight some of the things you said. Trust, extremely important. Belief, I'm not sure that's really an issue in Nigeria. I think Nigerians actually do believe in themselves, so that's not an issue. But I think as donors, the open-mindedness is absolutely important, and the need to support the needs of the people you're working with. Pull and push. That is how we make things work. But I think one other thing I reflected on as she was talking was that African proverb she alluded to, and I think it behoves all of us to keep that in the front of our minds. If you want to go fast, go alone. But I think we don't want to go fast, we want to go far. Therefore, we need to go together. So highlighting the importance of collaboration. But importantly, again, as a philanthropist, and I think Nigeria does not lack philanthropists, but I think perhaps the lack is philanthropy. So how do you actually go ahead and make good use of the money you have? And she's also told us the spirit behind that, the disruptive mindset. This is some learning for aspiring philanthropists in Nigeria to learn from. Innovative thinking. How do you innovate? How do you make things work? Because government can't do it all alone, and government is necessarily needs to work within boundaries. The philanthropists don't. The entrepreneurial insight. Things for our would-be philanthropists in country to take note of. I think I just want to end by linking what she said to actually this conference. And in my opening remarks, I spoke about thinking about the theme of this as field epidemiology. And what she said is in terms of philanthropists being able to react fast to public health incidents. And that is no different from field epidemiology. So thank you again, Valerie. Can we give her another round of applause? Time, okay. So moving on swiftly, please keep your questions in mind because we're going to have the question session when the rest of the stellar lineup speak. Next is another disruptor, I think. She laughs. So we have Adaora Ikenze, who is Facebook's head of public policy for West and Central Africa. She has worked across Africa, Europe, and the US as a lawyer, development expert, political advisor, and not-for-profit funder. Prior to joining Facebook, she held senior positions with the Global Fund for Women in San Francisco, Commonwealth Secretariat in London, and the Open Society Initiative for West Africa in Nigeria. She has also served as consultant to national and international agencies such as the Ministry of Petroleum Resources in Nigeria, Nigerian Maritime Administration and Safety Agency, NIMASA, UNIFEM, and the World Bank. She was a founding board member of Education as a Vaccine, Nigeria, and African Women's Development Fund, US, as well as a 2-term board member for the Foundation for Sustainable Development, US. She attended the University of Sheffield in the United Kingdom and Columbia University in New York for undergraduate and master's degrees, respectively. Join me in welcoming Adaora to give her talk on the role of social media and advocacy in preparing and responding to health emergencies. Adaora.
Good morning, everybody. Thank you very much for this invitation. I must say that it is absolutely humbling and extremely terrifying to be speaking to a room of people who are so much more intelligent than I am. So I will crave your indulgence. I will not be using lots of big technical words. I could just about follow Stacy's presentation. And I'm so glad that Dr. Bemo is here because at least I feel a little bit more solidarity on the non-technical side, although she's a doctor as well. So thank you again for this invitation. And when it was first passed to me, I thought to myself, my goodness, what on earth would I come here to say? And I spoke to some of my colleagues back in the office in London, and they said, oh gosh, the NCDC guys, they're so cool, we've been working with them. And I said, yes, but we have to actually go there and say something that makes sense to them. So we brainstormed, and what I'm going to present to you today is a snapshot of how Facebook sees its role and how it assists in providing resources and support for people on the front line, such as yourselves, who are working in health, in environmental issues, in policy development, on long-term strategies and short-term emergency responses. So the first thing that you tend to think of, I never get these things to work. Oh, okay. When you talk about social media, you don't necessarily think of the serious things in life. You tend to think, oh, we'll share some pictures, catch up with some old school friends, and find out what's happening in the world. But we, first of all, as a company, our mission is to provide the world with the tools to come together, to build community, to share experiences, and become closer. And we realized that part of that really is being able to put ourselves out there, being able to use our resources, being able to use the fact that we are disruptors to provide the tools to address immediate and long-term problems in the world. So, as you know, we have almost 3 billion people in the world that are on our platform every single day. And this provides us with incredible reach, incredible access, but also incredible responsibility. And what we do is really to provide data. We use data to address some of the world's greatest problems. We believe that when data is shared responsibly with the communities that need it, it can improve well-being, it can save lives, it can help how nonprofits do their work, it can help how researchers learn, and it can also help how policies are developed. We have developed a suite of products that we provide for free to the global community to address specific needs and to help facilitate answers to specific questions that people are looking at. We provide disaster maps, we provide disease prevention maps, we provide population density maps, and then we have a product, an in-house product that we call Insights for Impact, where we use data in collaboration with the organization or the institution that is trying to design a program to help them create targeted either campaigns or strategic plans or policy proposals or recommendations to help move the agenda forward or to help create immediate impact. Oops. Did I go? Yep. I went forward again. Sorry. I'm not good at this. It keeps going back and forth. So, okay, let me just talk about so in our disaster maps are, they are products, it's a product that you can either get before, during, or after the situation. They provide real-time information for response teams. You can help determine whether the communities have access to power or electricity or cellular networks or what the infrastructural situation is right there on the ground at that time. Now, because we are a social media company and because we collect data, we also have a great responsibility to make sure that people's privacy is respected. And the way we use that data is respectful and honest. So one of the things that we make very, very clear is that we only share, when we are putting together our data sets, we only use information that is already publicly available. We do not use data that has not been released publicly on our platforms. I will speak a little bit more about how that works out. But even when we are creating our data sets, we make sure that we anonymize them. We don't, we specifically smooth the data so that they are created in cells rather than using individual information. And you'll see that when I talk a little bit about our population density data sets. So, okay, fine. Why the one going? It keeps going up and down. I want to, yeah, move forward. Okay, thanks. Yeah. Okay. So like I said, our disaster maps, the information is de-identified and it's aggregated. We can generate them within 24 hours of a natural disaster. And since 2017, we have generated data for over 100 natural disasters, which have directly helped response efforts around the world. Map sets, like I said, we have, for the population density data sets, we only use non-Facebook data. We use artificial intelligence, machine AI learning, we use satellite imagery, and we use information that is publicly available. When we're looking at population movement, network connectivity, again, using the population on our Facebook platforms and electricity availability, we anonymize that. That is the Facebook data that is aggregated and is anonymized, and we use custom data pipelines. And the access to it is very, very strictly controlled. Institutions and organizations that request this data from us have to enter a legal agreement with us. Again, just to emphasize that when we are using non-public private data to create these data sets, it is de-identified, it's aggregated, it's smoothed, and there are specific legal requirements to access it. This is an example of our mapping of 4G connections in Nigeria. And this is just the southwestern region, and it shows you how detailed we can go in our mapping. This is another example of how we used our 4G mapping to assist in a disaster situation. And in Puerto Rico, we used the VSAT services to map to see where the greatest density of people were who were using internet services to reach out, to communicate. So the Red Cross now used that data to be able to identify where they could put their relief centers and their shelters, because they could identify where most people were and where they had most access to communication. We also, the second product that we provide are disease prevention maps. And these are really designed to help public health organizations, to help you close the gaps, in understanding where people live, how they're moving, the state of their connectivity, which will help you design better strategies to reach them, and to help you, improve the effectiveness of your campaigns. Again, with this data set, it is very clearly segregated. We provide, we use publicly available information, our satellite imagery and AI, and then we also use our aggregated, anonymized Facebook data through our custom data pipelines. And again, in order to be able to access that information, it has to be through a legal process. This was part of, this is an example of how our population density was used, our disaster, our disease prevention maps were used in Mozambique. So the direct relief actually used the data set to identify who was most at risk, where the people were, how they were communicating, and how they could best reach them. Our population density maps have been used by nonprofit and multilateral agencies to plan vaccination campaigns, to respond to national disasters. We use them, we provide them to evaluate rural electrification projects, for policymakers, to assess the ways climate change and urbanization can impact on us all. These data sets and these maps are fully available to the public on the Humanitarian Data Exchange. They use non-Facebook data, such as census data, satellite imagery, to identify areas and to estimate the number of people living in these areas, using squared grid cells. I'll give you an example again of, and they, I was told to say this. As you can tell, I'm not really a technical person, but the person who briefed me on this particular slide said I must say this. The resolution on these slides is unbelievable. It is, and I wrote this down, 30 by 30. I don't know what that means, but apparently it's something fantastic. So you can see a broad map of Nigeria, and then when you zoom into Lagos, you can see how detailed it is. We use the maps for this is this is an example of when the maps were used for a measles campaign in Malawi, vaccination in Malawi. So it was used to provide population data to help the Red Cross in identifying areas with and without people, concentrations of people. So they could get volunteers to get to households more efficiently because they knew exactly where the larger and less populated concentrations of people were. Now, this is our in-house project. This is our baby in Facebook. And this is where Facebook partners with NGOs, humanitarian organizations, NCDC, to help design strategic intervention projects. It could be a public information campaign. It could be a vaccination campaign. It could be a research project, to find out behaviors or sensitivities around particular things. And it is something that we are extremely proud of and extremely passionate about. So it really works in 3 phases. The first phase is we use our in-house NLPs to analyze public Facebook posts. And depending on what the topic is, what the issue is, what we're looking for, we look for specific words, we look for trends, we look at who is saying it, at what time are they saying it, how are they saying it, what are the sentiments being expressed about it, and we collate that information to give us a picture of what the sentiments are. What are we, because depending on what we're looking for, how do we find it? What are people talking about this issue? What is the age group? What's the demographic? What's the gender? What's the, at what time are they talking about it? What are the sentiments that they're expressing about it? To help us build out a picture of what we're trying to find out. And then we work with the organization or the NGO or the institution, to create targeted content. So if it's a vaccination campaign, if it's an information campaign, we will provide credits to the organization to boost content, to show on Facebook, to send the message out based on what they understand the conversation to be. And based on what they understand, what they want to share, we will provide support to get that message out on Facebook to the audience that we have identified. And then afterwards, we also help do an analysis. We do a study, a survey of impacts. Did it work? What were the results? What did we find out? We do it in-house, and the organization or institution can also do it, and we could do it jointly as well. So we did work with the NCDC on a campaign to increase treatment rates for meningitis. I apologize to Biodun because part of the reason why my presentation was late was because I asked them, I wanted to have specific information on how this works. And Dr. Higwazo, I hope you won't mind me just giving some pointers on this. So our analysis of public posts revealed that 81% of the conversation about meningitis in Nigeria was focused on vaccination. And interestingly, this was quite surprising to me, 66% of the conversation occurred between fathers and sons. So content was created featuring a father and son having a conversation about meningitis and emphasizing that meningitis is treatable. And this was a 2-week campaign that the NCDC rolled out across Nigeria. And apparently, the study revealed at the end of it that it reached 3 million people, 92% of whom said that they would recommend treatment to their friends and families. And we also did the same thing with UNICEF for Zika in Brazil. And again, the insights that came out of this, it was typically the same 3-stage process that we went through. We worked with UNICEF Brazil to understand the conversation around Zika on Facebook. Facebook tailored posts and pushed out content to their viewers to align with Brazilians' concerns about Zika. And at the end of it, the insights were that 58% of the posts on Zika in Brazil actually came from men, which made them, surprisingly, advocates for raising awareness and prevention. And then when people were asked if they planned to take action to protect themselves, 82% of the respondents who had seen the ads on Facebook replied yes, which was a statistically significant increase of 3 percentage points from the previous survey. So those are the ways that we as a company feel that we can best use our resources, our in-house abilities, our global reach, our scale, our capacity to pivot quickly and to provide access and resources to emergency services, to researchers, to policymakers, to advocates who are working on the front line to address some of the most critical and urgent issues in the world. Thank you very much.
Thank you, Adora. Yes, and the big masquerade that dances last is coming up now. Please. Okay, Professor Okolo has told me not to waste time, so I shall not be wasting time. I'll hand over to Professor Okolo.
Thank you. Thank you very much, Shola. And you see, if you had wanted to introduce me, you could simply say the disruptor. And the reason I'm a disruptor is because, as you can see, this is an all-female panel, and I'm the only male. That's not the only reason. The second reason is that I'm in a house full of public health physicians and others who are interested in public health. I'm not a public health physician. I'm a gynecologist. The third area where I'm a disruptor is that I have conveniently left the practice of clinical medicine and academics to now go into diplomacy. And I know that from time to time, there are certain things I would like to do or like to say, but I can't. And so the final area of disruption is that I haven't got slides. So I'm going to talk to you from the speech that I have, and I'm going to, as much as possible, try and catch up to time, if I can. I know you gave me 20 minutes. Let me try and see if I can do this in 10 or 15 minutes. First of all, thank you, Chikwe. Thank you, NCDC. Thank you to your fantastic team for inviting me to the conference and for associating the West Africa Health Organization with this initiative. I applaud the drive, dynamism, and determination that you, Chikwe, bring to assuring health security in Nigeria, the most populous nation of our region. And indeed, Black Africa, Nigeria is the most populous nation. More grease to your elbows. Thank you, Patrick. AFNET, you are doing extremely well. We at WAHO have partnered with you, and as part of one of my first things when I took up office was to sign the MOU to try and see how we expand the capacity building in West Africa. I also want to thank all of you here, public health practitioners, partners, decision and policymakers, support staff, and indeed members of the press for attending this scientific conference, showing that you have a commitment to acquire and use evidence for public health action in various countries. Be assured that we at WAHO and indeed in ECOWAS, we will support most of your activities. And for this conference with the theme of West Africa, with the theme you have, you've given me the specific task of talking to you in about 20 minutes on regional efforts in strengthening public health systems for health emergencies and disease outbreaks. And I think it's appropriate given the things that are happening in terms of Africa, the Ebola epidemic in DRC, and we are therefore very pleased to participate in this conference. Now let me just give you a small perspective in terms of West Africa. So West Africa has 15 West Africa actually has 17 countries, but we have 15 countries in ECOWAS. Now, ECOWAS had originally 15 countries, and though Mauritania, which was a founding member of ECOWAS, left ECOWAS after 2 years, Cabo Verde, or Cape Verde, joined after 2 years. So we still remain 15. But you know that, of course, if you include Mauritania and you include Cameroon, which we want to claim sometimes, then we have about 17 countries in West Africa. Our region regularly witnesses multiple health emergencies and disease outbreaks, even if they do not reach epidemic proportions. In the first 8 months of 2019 alone, we've had about 8 public health emergencies. Cholera in Nigeria, Niger, Benin, and Togo, measles in Mali, Liberia, Lassa fever in Nigeria, Benin, and currently we're dealing with the Lassa fever outbreak in Liberia, yellow fever in Nigeria and Cote d'Ivoire, or Ivory Coast, dengue fever in Senegal and Benin, and meningitis, which often reported in a lot of our countries. We also have had natural disasters, which of course, constitute public health emergencies. When you think about floods in Sierra Leone and Ivory Coast resulting in casualties, or when you think about what Boko Haram is doing in Nigeria, or the terrorists in Burkina Faso and Mali that are leading to huge problems with internally displaced people and the public health impact of that. So, our problem with recurrent public health emergencies is compounded by the fact that our region also faces challenges with infectious disease surveillance and response infrastructure, and also inadequate laboratory facilities, problems with governance and coordination, and indeed, an inadequate number of public health workforce. Let me tell you about WAHO, the organization that I work for and that I didn't know anything about until I joined. It is a statutory intergovernmental organization. It is the health arm of ECOWAS, the Economic Community of West African States. And although there are 5 regional economic communities in Africa, it's only ECOWAS that has a health institution, The others either have a health desk or health personnel, and it's only ECOWAS that the 15 heads of state and government, in their wisdom, felt that West Africa needed to accord importance to health, and as far back as 1987, they took a decision to set up WAHO, but it became operational only in 2000. And I will come back to this when I talk about how slowly things move and how you find that when you take a decision, it doesn't always, or when you have something you want to do, it doesn't always move as far as that. Our mandate is really to promote regional integration across West Africa through health. And this mandate often involves strategic political advocacy. So we meet with ministers, we convene ministers. We also report higher up to the heads of state and government. And we also have to facilitate policy dialogues and development of regional networks that provide peer support, but particularly in what we're discussing for the theme of this conference, assure health security. So as you can see, our remit is huge. I don't know if, by the way, somebody was saying, Biodu, you sent Biodu's slides yesterday. I sent Biodu's slides an hour ago. So I think she is fantastic. Biodu, do we have any slides for me? Can I have the first one, the PDF? If you don't, it doesn't matter. I've said I don't have slides. But if you do, can I have the first one? Okay. Now, the first one is simply to say to you that our remit is huge. And what we've been asked to do is to do everything health. Everything health, from pharmaceuticals to regional centers of excellence, to communicable diseases, to capacity building. And we are not ministries of health in any country. We are simply a regional body. And therefore, we have to focus. And that's why I put up this slide, to show that what we have done was to sort of thematically focus everything we do in one slide. And we have brought them under themes. So when you then break down those green columns, which are the themes, you will find that within them you start teasing. It's like peeling an onion. And then you find that some are bigger than others. But we think that these are the key critical areas that we want to work on in the next 3 to 5 years. We have enablers, which are on the left-hand side. So you have the need to build capacity, the need to strengthen the regional networks, and the need to have an eye for sustainability. And we never, never want to lose sight of the focus, which is population impact. So let me emphasize only 3 major areas that would illustrate our role in strengthening public health systems for health emergencies and disease outbreaks. 1 is advocacy and policy making. 2 is strengthening of systems and networks. And 3 is capacity strengthening. And these are the only 3 areas I want to share with you in talking about regional efforts to sustain public health systems. Our ECOWAS Regional Center for Surveillance and Disease Control was again set up by a decision of heads and states of government in December 2015. Today, I'm ashamed to say to you that in September 2019, we still don't have an executive director. Despite all the efforts we are trying to, we have got it operational. So at least there is a little bit of effort. We've put in some heads of departments there. So somebody was saying to me when I was coming in that Virgil Lokosu was here yesterday at the workshop, yes, and that his talk was extremely well received. I'm very proud of him. He is now moving from our headquarters in Bobo Dioulasso to head the Preparedness and Response Department of our RCDC. That's one of the key people and key leaders of public health that we want to put in our RCDC in Abuja. The RCDC is here in Abuja. The RCDC's role includes championing of adequate laboratory infrastructure, improved response capacities, as well as training and research across our region. And in addition to our role at WAHO in creating institutional capacities for RCDC, we have also championed the establishment and development of national public health institutions, which is called in our region, National Coordinating Institutions, in each country, to ensure a cohesive approach to the core components of IDSR. This we achieve not only through political advocacy to the country's ministers of health, but also as part of the major area I wish to highlight, the next major area I wish to highlight, which is the strengthening of systems and networks. Now, let me just tell you upfront one of the challenges that we have, or that I found and we have in West Africa, but it is also an advantage because you can exploit challenges. And that is the cultural challenges of language blocks. We have a Francophone block that constitutes 8 countries. We have an Anglophone block that constitutes 5 countries, and we have a Lusophone, people who speak Portuguese, that constitute 2 countries. And they do things differently. But we all have agreed to come together as a people rather than a community of states. So it is something that we all have to constantly work on. And I challenge all of you in Nigeria. You're like, I'm sorry to say, because I've spent a lot of my professional life there, but actually I think I have evidence to say that you're a bit like the Brits, okay? You only speak English. You only think about Nigeria because Nigeria is so huge. And that's what's happening with Brexit now, isn't it? Okay? I spent more than 30 years of my professional life there, and I only left Britain last year. Now, we should try to look across our region. I'm so proud of you presenting in English, and I hope I will present in French someday. I do communicate in French now. I haven't been taking my French lessons since last year. But across the region, a lot of the youth speak English. Those who are French and those who are in other languages, they do that. So they have that ability to see West Africa as one. Second area I'm talking about is strengthening of systems and networks. In addition to championing the strengthening of MPHIs, we provide technical assistance to member states to implement international health regulation core standards. And we undertake through the NCDC a regional coordinating role regarding health emergencies response. But this is in alignment with Africa CDC and close collaboration with WHO. It is really important to emphasize this, that there is no paper of difference between what the RCDC here in Abuja is the hub of the Africa CDC, and we must support those continental efforts. Personnel from Africa CDC are embedded in the RCDC, okay? And at the moment, although the director running the RCDC runs it from WAHO headquarters, we hope that before the end of the year, we have an executive director who is situated in RCDC. And that executive director will have a dotted line of accountability to John Nkengasong, the ED of Africa CDC. The operational map and governance framework is therefore structured to ensure a seamless and effective coordinated approach to surveillance, preparedness, and response activities, both regionally and continentally. And that need for alignment is very important. There are several ongoing work streams and efforts aimed at strengthening the regional networks. That networks that I said we'll try to strengthen. Activities such as our regular situation analysis studies on specific disease outbreaks with health emergencies, which are then shared through a regional epidemiological bulletin that we publish. The laboratory antimicrobial resistance work stream, which brings together the countries in terms of their laboratory experts to look at the regional reference laboratories that there are 3 in Nigeria, including, what's her name? Claire has left? Stacy, sorry, I was speaking to her. Including the veterinary, the one in VOM, and also we try to build these networks to try and build trust and confidence across the region. Somebody talked about trust and confidence because that is very important amongst actors in building public health security. Other efforts include supporting and instituting regular simulation exercises. Some of you were here at the CIMEX in Lagos last year, and other similar simulation exercises we are holding across the countries. Guinea had one recently. We also try to support by establishing an ECOWAS regional rapid response team. As I'm speaking to you now, we have sponsored 3 people from, and Chikwe, thank you so much for releasing them, 3 people from Nigeria CDC to go to Liberia to support them, to do a fact-finding mission, to bring us back in a week or 2, how is it that we can rapidly get the Lassa fever outbreak in Liberia under control. These are the essence of regional networks and in terms of peer support. We also have a regional contingency stock, which is in the PSP, yes, or Nouvelle PSP in Abidjan. for public health emergencies where countries can come and borrow stock and then replenish, although they don't always do that. We're also partnering with the GIZ in Nigeria here in terms of risk communication. But the GIZ work is focused on 4 countries. Third major area I want to talk to you about is capacity building. Workforce development is key for not only us, but also for the region due to its fundamental importance in epidemics preparedness and response. We still face major needs and gaps of skilled manpower. I understand, and I just confirmed that from Chikwe, that if you're talking about Nigeria, for example, in terms of advanced epidemiologists, we're only at a coverage of about 30%. We have only about 300 advanced epidemiologists when there is a recommendation that we are following. If we do that for a country as big as Nigeria, we probably should have 1,000. So we need to rapidly train up 7, and we're not talking about frontline, we're talking about advanced. Our own 2018 data, can you just roll this on, because there is a slide that will show that we have about 3,000 frontline epidemiologists and only about 400 across the country. So if you, no, roll up here. No, not this one. Or is it this one? No. Next one. That. So you can see across the whole region of West Africa that we really do have to improve this. So we're pushing. Chikwe is here. I love Chikwe's word. Keep pushing. Chikwe? Yes? So we keep pushing to address the critical needs and gaps of member states, to institutionalize NFELTP within NPHIs with partners such as AFNET, and to ensure a comprehensive workforce development strategy. I am not embarrassing you, but I must say that BMGF have been very key with this, and we are talking to them at ECOWAS Commission level on human capital development, and unfortunately we can't have the meeting that we wanted to put up at ONGA this year, but hopefully we will have it soon. And so we are looking at a bigger picture in terms of doing this. I now need to call on all actors, state and non-state, to consider more investments in human resources for health to support countries' efforts in workforce development. Finally, I hope I haven't taken too long, a little mention that of the fact that WAHO is mobilizing partners in strengthening health security in ECOWAS region. Whether it's infrastructure in terms of emergency stock I've talked about, in terms of building laboratories through our ProLab projects, or in terms of actually building cross-border health centers. We have 2 at the moment. I'm going to sometime next month hand over to the president of Liberia, one that we built in Bowater side, which is on the border between Liberia and Sierra Leone, and we'll have another one in Sierra Leone. Recently, we had emergency operations center training for liaison officers, and for which we run with US CDC. And so there are several things that we're doing, and we continue to develop vibrant partnerships with key implementation partners in the areas. What are our challenges? I've talked about the cultural challenges. There is a challenge regarding the independence of NPHIs. And this is one of the areas where I now have to understand that in my last role, the last job I did before I came to this, I was a medical director. You told people what to do, they did it. Okay? Now I've come as a diplomat trying to bring people together in countries. Ministers, you can't tell them what to do to start with, but also you have to coax, and therefore the independence, as we have in Nigeria of NCDC, doesn't cut across all NPHIs in our 15 countries. So we keep advocating on that. That is one of our challenges. Second challenge we have, comms, communications. It's really important. Babaka, one of our professionals, is here in the room, and he's responsible for communication. He's set up a WhatsApp group, he set up communication strategy. We have regular communications, but sometimes we still have a delay of about 24, 48 hours before we're informed of outbreaks. And then the third challenge that we'll have, which is something that we're really going to work on in 2020, and we've put it in our budget, is leadership for governance. And I say leadership for governance, which is quite distinct from some of the leadership in terms of technical skills that you have found, or actually some of the leadership that are within the Africa CDC Workforce Institute. But we're thinking of how do you lead? How do you ensure that you equip people with the skills and the capacity as health leaders and health managers? And that is something that is really important for us. In ending, I wish to use this important occasion to extend our gratitude to the government and people of Federal Republic of Nigeria for their renowned hospitality, not only because I'm a Nigerian, but also because I'm welcome, I hope, back to my country. Our base is in Burkina Faso, so whenever I leave Burkina Faso coming to Nigeria, I say I'm coming home. I want to thank you and congratulate you for this conference. Thank you so much.
Thank you, Stanley. Obrigado. Merci beaucoup. Thank you. Having said that, we really don't have much time, but you can agree with me that we've had a real stellar lineup. We've looked at laboratory surveillance, we've looked at philanthropy, we've looked at Facebook. Whoever knew that Facebook had, well, I didn't know, such data tools. And can I ask you again to give our speakers a very good round of applause. Thanks a lot. Because we're really working to time, and Stanley has reminded me that we really need to be on time. Unfortunately, we won't be able to take questions, or can we? Right, okay. Oh, Patrick. But I must say that please keep your questions in mind. They're still with us, I hope, for today. And then you'll have the opportunity to actually ask them those very burning questions that, unfortunately, we're not able to take. Having said that, I think the organizers will give us information on what next to do in the program, but there is something else we need to do as well. Yes? Okay. So what is it? Okay. So meanwhile. Okay. Biodu. Yeah. Well, while Biodu is coming, I think I just want to make a comment on Stanley's one. He really gave us a good overview of what WAHO is doing, and not only the overview, which I think I found quite informative, but also some of the challenges. But as he said, he will keep pushing, and so we would be looking forward to how those challenges are solved going forwards. So, Biodu. So I've been asked by Biodu, who is to ask Chikwe to please come to the podium. And I think we cannot but appreciate the efforts of our speakers this morning. And apart from the speeches this morning, I think this is also in recognition of the work they've done, certainly with the NCDC and with Nigeria, and of course, regionally. So I will invite Chikwe to give us the first award to Adaura Ikenze. Adaura. And of course, Stanley was quite right. I didn't have the opportunity to say that. Valerie just blew me with her English. And I couldn't just, I was just listening to her English with that very lovely French accent. So inviting Valerie also to receive her award. Thank you, Valerie. And to the big masquerade that dances last, Professor Stanley Okolo, DG of WAHO. Yeah, thank you. So just a few announcements. Thank you, Chikwe.
So, thank you all for being here once again. And we'd like to say thank you to all our keynote speakers for the great presentations. We'll go straight to the parallel sessions. We'll be having walking tea breaks. So there are 4 parallel sessions that will be taking place, one here in the Congress Hall and another in the FCT Hall, which is upstairs by my left. And then we have Kano Hall, also upstairs by my right. And just next door, Edo Hall. There will be 4 parallel sessions taking place there, and the tea breaks will be served in all the halls. For those persons that would like to stay in the Congress Hall, the tea is served at the foyer just outside, so you can pick the tea and then come in for the presentation. We also like to still announce to everyone that we should be security conscious. Please ensure that your bags are with you at all times, and you will not be allowed into any of the halls without your tags. The lavatories are by the right, and I wish us all a very wonderful time. Thank you.